Our next speaker is Dr. Ralf Kuhlen from Germany. Ralf is the Chief Medical Officer at Helios Health, which is a private health hospital organisation in Germany that also operates in Spain. Ralf was appointed to the international holding after he served as the CMO at Helios since 2010. And he's a trained anaesthetist and worked in clinical and academic roles before he joined Helios to head their ICU in 2007. Today, Ralf's going to speak about an initiative, Quality Medicine, and a peer review system for monitoring quality and safety that they've set up in Germany using DRG data. So that's what it's the great interest for us. I was lucky enough to meet Ralf at a conference in the US last year where he presented some of this work, and it's a really good example of how we can use all this really rich data we collect for a whole lot of purposes, but beyond just funding. And I think this is a really good example of this. So please join me in welcoming Ralf.
So, good morning to everybody. I think it's a challenge in itself to have a German anesthetist who then went into management, talking after lunch about quality medicine. I tried to do my very best. I'm still on German time, so it's 6 o'clock in the morning for me. If I tend to be a little bit sleepy, I'm sorry. The initiative of quality medicine is, as James pointed out, something we are doing for the sake of quality and improving quality out of the DRG data we are having. However, I thought it would be a good idea to give you a little bit on the background of the healthcare system in Germany we are talking about and the issues we are facing, to put it a little bit into perspective. First of all, my company, Helios Health, is a German-based company, hospital group, which meanwhile is operating in Germany and in Spain. We are holding 155 hospitals, approximately 400 medical centers. Altogether would be 42,000 beds, roughly 110,000 employees, and we oversee the data from 1.6 million inpatients every year and around 14 million outpatients every year. So quite a bit of data, which was the ground for what we are talking about when it comes to the initiative of quality medicine. Here, I'm representing this initiative. That was my company. In this initiative, I was one of the founding members, and I'm chairing their scientific committee since a couple of years. Meanwhile, in the initiative of quality medicine, it is like 450 German hospitals, Swiss hospitals, another 40, and the system I'm presenting today became the statutory quality management system in Austria. Therefore, you wouldn't see a number in Austria. The little tiny thing on the lower right is Austria. But it became statutory there. And you've seen the data from the Helios group. There is quite a bit more data here going over the different hospital holdings, if you want to, from public to private to whatever it is. And I think we can overview quite a number of data and experiences. Maybe some words on the background of the German healthcare system. Maybe you know that a complete DRG system has been put into place in 2000, and since then some major changes happened to the German system. As you can see, the amount of hospitals decreased, the amount of beds decreased. However, activity increased pretty much. We are admitting approximately 25% of the German population as an inpatient case every year. This is world record. And James, you said yesterday in the opening, an activity-based funding system results into activity. That's true. We have that in Germany really as a good and maybe sometimes bad example. The average length of stay decreased. However, we will put that into perspective into what the OECD data is giving us from Europe, and it's still way too long in Germany. Physicians increased. Nurses decreased. Nurses decreased not because we didn't want to have them, because we have a severe lack of nursing personnel. And that is an issue which I guess is something we have to discuss. However, the question is, how do we discuss it? If you would compare the infrastructure in Germany to the rest of Europe and some international on the right side, unfortunately not Australia, I'm sorry for that one, but the OECD is not doing Australia. Germany is having a huge amount of hospital discharges or hospital admissions per capita. We are having a huge average length of stay in the hospital, although we decreased it pretty good. In Spain, by the way, it's almost half, because they don't have any border between the inpatient and the outpatient sector. So they can do whatever they want on an inpatient or an outpatient basis, which is decreasing the length of stay tremendously. We have the highest amounts of hospital beds in Europe, I guess all around the world, to be honest. And this is an issue, because the infrastructure is a problem. If you would count the number of doctors per capita, it's good. If you would count the number of nurses per capita, it is good as well. It is much better than the European average, definitely better than in Spain. However, since we are having such a vast amount of beds, the nursing per bed is an issue. That is strictly a problem of the denominator. So we are talking very much in Germany about the reduction of infrastructure, which has grown up over the last years for many, many, many reasons. When it comes to healthcare efficiency, it's particularly interesting to travel to Australia, because as you might know, there is numerous international studies looking into efficacy. Efficacy means what value, what outcome is resulting from what cost you would spend into your healthcare system. And here Australia is doing really good. And Germany is at best doing average. Spain is doing as good as Australia. So here's something to learn for, I guess, all of us. And this is something which is quite interesting for me to see what you are doing here. I think the three potentially most important factors for a successful healthcare system would be really generating value. We talked about that one yesterday, and I'll come to it in a minute. Value for the purpose of that presentation is simply quality or outcome over cost. We need to talk about the use of data. I guess everybody is talking about it, but we need to do it in a rational sense. And we need to have people who are able to do their jobs, who are trained, skilled, committed, dedicated, whatever it means. And I guess that is one of the major issues for all of us. I'm talking a little bit about the first one and the challenge in Germany. I'm not so sure about the Australian society, but yesterday I've learned that aging population is an issue for you as well. In Germany, it's a severe issue. As you can see, we have had and when I was born, 5 people who were paying for 1 retired. Now it's 2 who are supposed to pay for 1 retired, which is simply not working, as you can imagine. The same is true for healthcare. There is simply, in an aging population, the issue of the workforce decreasing, but the patients are increasing. Now, if you look into how do we translate this into health, I'm sorry, the yellow one is health in German, gesund. How do we translate that? We need to talk about people, we need to talk about the process, and we need to talk about the infrastructure. The classical way, at least in Germany, was we talked about structure and people. Not that much about process, structure and people. And whenever there was a problem, we increased the structure, which tends to be quite a natural reaction for political bodies. That happened in Germany all around the place. We cannot follow that path because simply the people are not there. So we have to think about the process. And most of the times when value-based healthcare is put into perspective, the perspective is money. My perspective here is people, because we simply don't have them. And money is an issue as well, no question about it. But when we are talking about value-based, I think that is the 2 major reasons for really talking about it. And that's the reason probably why there's a worldwide interest into value-based healthcare. as we have discussed over the days and is discussed actually in any conference around. The OECD has put up a program where I think, quite notably, they pointed out that the reduction of waste is probably the first step when you want to create quality and efficacy. And that's from an old slide from my presentations. How do you generate value? Reduce waste. That's really hard to do in medicine. Be effective, meaning do the right things, and be efficient, do those things right. And the whole thing we are talking about here, the initiative of quality medicine, is a way to get there. And Shane, that is for you. You talked about that yesterday. If you would ask somebody in a hospital what actually is quality or any value, then you would come to immediate answers, but they are very much dependent on who would you ask the question to. And that is completely different between patients, employers, doctors, nurses, managers, owners, politicians, whoever it is. And the second one, which is true, is that everybody wants to have the innovation, but no change, which is hardly possible. But the good thing is that's true for all of us as well. So we tried to be simple and took decisions. You all know those classical cycles on quality management. We took a decision to look into outcomes, and whenever something is wrong with the outcome, we look into process and structure. We do that by peer review. I explain it in a minute. And we have to have a clear plan if we want to do quality management. What is the purpose? And our purpose is clearly to improve. So we are measuring for the sake of improvement. We are not measuring for the purpose of comparison and stating I'm the best, or I'm second or third or whatever best. That is a big issue when it comes to quality indicator definitions, as we will see in a minute. We take basically whatever data is around. The DRG data is around on 100% level. We have the ICD-10 and the German OPS, and you can use them because they are around for all inpatients, private and public. So everybody has them. And then we measure them by defining quality indicators, and we put them on the web. True, we think that public reporting is a self-explaining necessity because we're talking about patients and their data. I would never argue that public reporting per se is increasing something. I would never argue that measuring per se is doing something good. You have to do something about it. And the active step of doing something about it is what we call the peer review. And I'm trying to explain this in the next 5 minutes. When the DRG system was implemented in 2000, we tried to do it within the Helios group, measuring, defining indicators, making them transparent to everybody who's working with us. To everybody means to everybody who is having an email address within the Helios group. So all the catering, cleaning, whatever personnel, all the managers, all the doctors, everybody. And then we do the peer review, which was done publicly as well. That was so successful that we implemented it in the whole group. And then in 2008, we decided to open the doors and founded the Initiative of Quality Medicine with others, at that time together with 15 different hospitals. And I think based on the very successful story since then, people at IQM would claim quality leadership. And I think it makes sense. What is IQM? It's a non-profit organization which has been founded by 15 hospitals. Our members are running acute care facilities, and the only precondition if you want to be on there, you have to have the DRG data, because that is the databases for the indicators. The number of hospitals, apart from Austria, this is statutory, we don't count, is around 490. I guess in our last membership assembly a couple of weeks ago, we had more than 500, and we are overseeing more than 7.5 million inpatient data points. Whenever it comes to discussions on definitions on indicators, there might be errors in there, no question about that. They are never perfect. But when you do it on such a large scale, then it becomes comparable. We measure, we show it to the public, and we try to improve. That's what we are really trying to do. We take the billing data, principal diagnosis, secondary diagnosis, all procedures are in there, age, sex, length of stay, ventilation, reason of discharge, whatever. So everything is in there, and this is the basis for defining the indicators. The advantage of routine data is that they are, at least for the inpatient, 100% available, and they are being controlled because this is the data which is going to the insurance company for reimbursement. And they have their controlling authorities as well. So it's not only that you would code the data, it's being controlled. And that's the reason why we would take them, and by taking our indicators, we would cover around 45% of all conditions being in hospital. We take whatever data we can get. The German inpatient quality indicator set is our main source. That is the DRG data. We do it for Swiss because the system is a little bit different. Meanwhile, we're doing it for Spain as well. We can translate, and if we wanted to translate in different systems, I guess we would be able to do. Maybe that's of interest for us to benchmark ourselves. We take the external quality assurance, we take the HRQ data, for example, the patient safety indicators, and all this is done with the help of 3M, and that is very helpful because they do all the data handling, because you can imagine when it comes to the handling of more than 7 million data points, that really is an issue. And Germany is really hard place for the GDPR regulations and the data safety issues, very, very, very cautious about it. So having 3M at our side is really an advantage. You would send the data there, and we do it twice a year. Could be done often, more often, but we do it twice a year on a regular membership basis. And then within an hour after you would send the data there, you would have a quick report back on your data to check plausibility. Then a couple of weeks afterwards, you will have the benchmark report back within the IQM hospitals. So you would see everybody there open, so with the names. You can compare to who's best, who's doing not so good. You have for the individual hospital a viewer based on file inspector, which would allow you to go into the case by the case number. That is for the internal reviewing processes only within the hospital. That is nothing which can be seen by others due to data safety reasons. And all of this has been put together into a web report with some fancy reports being above there, like funnel plots, box plots, geoanalysis, whatever it is. So 3M is really doing a great job in collecting the data, handling the data, analyzing the data, and giving them back to the membership. The main system and the main structure how to present the data to the public is, for example, acute myocardial infarction. There is a target value. The target value is coming from the German reference data from the InEK Statistical Bundesamt. That is all German data. And then you would see the IQM average data in your hospital. In our case, it was a bad example because the hospital had a mortality rate of 14% and thereby an SMR of 1.8. So you have to do something about it, taken by intention, because that is the typical issue where we do something about it, the peer review. The quality indicators are not meant to be reliable indicators of quality. They are meant to be triggers for where does it make sense to look after. That is a tremendous difference, because if you want to compare, you come into discussion on fairness, risk adjustment, whatever, and it needs to be discussed. If you would take it for the sake of improvement to do a peer review, it is important not to compare apples to oranges. Yeah, that's true. But the amount of risk adjustment is much more important than if you would go for comparisons with it. And the peer reviewing process is the real part about it. So what is the peer review? In the hospital you've seen with the acute myocardial infarction, we would say, okay, let's have a look at that hospital. What are they doing there? And the look looks like this. There is the peer review group, doctors in the field, nurses, managers sometimes, if it makes sense. And they are discussing real patient records in the respective indicator field with the clinical team. And you can imagine that this is a sensitive situation, because they are not going there because they wanted to visit them anyhow. They are going there because the SMR is 80% above average. So that is sensitive per se. So the real issue about the peer reviewing is the reviewers need to be trained. They have to be experts in their field, no question. But they have to acknowledge that the arrow culture and the culture of continuous improvement and to create the atmosphere of doing a peer review is an issue as well. And if you would ask me, we have many experts in the field, but being aware of this social competence is the issue. And that's the reason why we do that together with the German Physician Council. And we have a curriculum. It's a weekend workshop where you are being trained there, and then you are a certified peer reviewer, which is not necessarily meaning that you're a good peer reviewer, but at least you are a certified peer reviewer. You know the problem. That's good. So what do we find in the peer reviews? That is 70% of all our issues. It is hardly ever the major bug. Somebody did something terribly wrong. That happens, okay, but that is really not accounting for the majority of the instances we would see. That is daily life. Communication errors are around 75% because communication is not structured. Not because somebody intends something which is not good, because it is simply not structured. Anesthetists are not talking to internal medicine people, not talking to surgeons, not talking to patients. And so if we try to improve this in a general setting, we would talk about structures. If we would try to improve this with patient charts being on the table, you really talk about daily life. And that's what they do in the peer reviewing. It has been chosen to decrease the SMR, which necessarily was above 1 before we did the peer review. That is the trigger of going there, down to average. It is a perfect measure to create average quality and to improve sub-average quality. It's not necessarily something where you can make an expert, a world champion, out of average quality. But this is good, I think, for a healthcare system. This was retrospective. We are now doing the biggest prospective analysis, which is running right now, being with a major grant from the German Health Ministry on the prospective effect of peer review. If that proves positive, I hope, we will have the data by September this year. That would be a major step, because then it's really a proof for doing it. So, does that work? Yes, it does. I showed you the data from the Helios group. This is again acute myocardial infarction because we talked about it. That is the German average you would see in the lighter bars and Helios, and you see, yes, they are doing better than the German average over the years. We have bad hospitals, that is true, but then you go there and review and then you would improve. What is the reaction to pure benchmark? I'm sure all of you know about. The figures are wrong. We've got the more serious cases. You can't compare as well the departments for various reasons. Our working environment is completely different. And this is true in virtually all of the cases. And this is not causing the differences in virtually all of the cases. So you have to admit that there is room for improvement. You have to accept that you are able to do something about it, and then it's a good idea. When we do the peer review, it's like an iceberg phenomenon. We see the indicator, but we see so much process below the indicator, below what the indicator shows, that if you improve something on acute myocardial infarction, you will virtually ever have a collateral benefit, for example, for congestive heart failure. So this is something we think is really worth to do, and that's the reason why we are traveling quite a bit. As I told you, we do that together with 3M, and as I told you, the German average might not necessarily be the best average to compare with. That is the reason why I would be interested in, for example, Australian data, as we talked about, James, I would really be interested to see how other healthcare systems are doing, and if they are better doing, I would like to see why they are better doing. So that's the reason for traveling quite a bit. Thanks for hosting me, and it was a pleasure for being here. And now I'm open for the discussion. Thank you.
Okay, have we got any questions for Ralf? Got nothing on the app.
Everybody's in lunch break.
Here comes the microphone. I just checked at 6 a.m. in Frankfurt. Yeah.
Is it?
Yeah.
You shouldn't have told me.
Wake up.
Just a question. Do you have coding teams in your hospitals in Germany, or do the doctors perform the coding function?
Both. We actually do have coding teams, but what they normally do is after the doctor did the primary coding, they would control it. So doctors usually are doing the coding by themselves, which I guess makes sense because it's, if you look into the whole process of coding, it's, I would say 95% is taking a diagnosis and having a proper documentation, and then you have to find the code. And doctors in Germany are trained to it. They don't love it necessarily, but they're trained to it. And then it's controlled by coding people.
Ralf, thank you very much for your presentation. It's always very stimulating to hear some of the great work that's going on in Germany. We've heard a lot in the last 2 days about patient-reported outcomes being a key ingredient to driving quality improvement and improving the value in healthcare. So I'm just interested the extent to which you might have also factored in PROMs as part of your work, as part of your peer review process, as part of identifying opportunities to improve performance.
Well, thanks for the question. Very well taken, and I talked to Andrew about it in the break. Actually, we founded it in 2008, and we are doing the same thing for the last 11 years. Now we are doing a major reconstruction, if you want to, of our indicator set, and we are incorporating PROMs, which I think makes real sense. So PROMs will be another trigger for benchmarking and then doing a peer review. And I think it really makes sense, because having quality indicators, as sound as they are, but having a feedback from the patient is really something which is coming more close to what we are actually doing and are supposed to do. So yes, we do take it, and then we, hopefully I will be able to report on it in the next 2 years or so. That is quite an issue, because there is no data set readily available for analysis. So we have to put it all together, and we have to find the rules, and the benchmarking issue is an issue, because PROMs for one hospital might be slightly different from PROMs from the other one. So we have to standardize and everything. But yes, we are doing.
Thank you very much, Ralf.
Thank you.